panel of experts, dear moderators and learned audience. Assalamu alaikum. Today I am privileged to present a research report on breast cancer prognosis. The title of our title is Survival Probability of Breast Cancer Beyond Serial Axillary Dissection, Prospective study. I am Professor Mostaque from Gonoshayastha, Professor of Surgery, and our co-presenters are Dr. M. Kamal, BSBCS Dhaka, from the Department of Pathology, and Professor A.M. Sharifullah, Clinical Oncologist of Axillary Mission Cancer and General. We know regional lymphadenectomy is a well-established surgical modality of treatment in carcinomas, including head, neck, thoracic, abdominal cancers. Right now, tumor stage 1 and 2 represent 70% of breast cancer, where axillary lymph node dissection are replaced by sentinel lymph node biopsy. Extended regional lymph node dissection is indicated in gastric cancer surgery because it increases overall survival by 7 to 11% for removal of every 10 lymph nodes up to the 40 lymph nodes. Pathological node space or TNL counts positive lymph node only to forecast prognosis of breast cancer patients. Hence, ignoring therapeutic value of axillary lymphadenectomy. Only positive lymph node count might not express prognosis of breast cancer powerfully because wide variation of axillary lymph nodes. We know in the axilla as minimum as 5 lymph nodes may present there and as maximum as greater than 13 others. Axillary lymph node ratio, which is a measure of proportion of cancerous lymph nodes, that is positive lymph nodes, to the total number of lymph nodes removed, might efficiently forecast prognosis as it expresses regional tumor burden. Our objective of this study was to observe power and precision of expression of prognosis of disease-free survival and overall survival. We call it events by the pathological node, staging, and linear subgroups. Disease-free survival is defined as time in months from date of surgery to date of diagnosis of recurrence. And overall survival was defined as time in months from date of diagnosis to date of death. This prospective study was conducted on 51 consecutive breast cancer patients between August 2016 to December 2019 after obtaining written consent of the patient and permission of Ethical Board of Axillary Mission Cancer and General Hospital, Dhaka. The exclusion criteria was when a breast cancer patient presented with metastasis at the time of presentation was excluded from this study. We know pathological node stage of tumor with metastasis was recorded as pathological N0, node 0, that is no positive lymph node, with best prognosis. And pathological node 1, pathological node 2, and pathological node which indicates worst prognosis of the patient. And at the same time, LNR was classified as low risk LNR, indicating best prognosis, intermediate risk LNR, and other is high risk LNR with worst prognosis. The patient distribution, mainly we observed out of 51 patients, only 4 patients belongs to pathological node 3 groups, which is about 8% of the total. On the other hand, in Illinois group, we observed high-risk Illinois number of patients was 9, that is about 18% of the total. And this difference drew our attention for deeper study of the lymph studies and progresses. Median follow-up according to December 2022. This date is because at that date, before that date, all of the patients of high-risk illness was dead, and our disease-free survival as well as overall survival was greater than 4 years within this December 2022. We observed number of recurrence was 70, that is about 33%, and number of deaths 21, which is about 41%. Distribution of death among pathological node stages. We observed pathological node stage 2 has 10 deaths, and pathological node stage 3 has 3 deaths, only 6. Difference was not significant. On the other hand, according in death distribution, Illinois subgroup was intermediate is Illinois 5, that is about 10% of the total, and high-risk Illinois all same percentage, which is about 18% of the total. And we observe highly significant difference. This is the Kaplan-Meier survival function curves of disease-free survival of pathological node stages. Here we observe that pathological node 2 subgroup patient indicates post-prognosis from the point of view of the disease-free survival. And the pathological node 3 subgroups have a discordant curve. This is very important. And we find there is no significant difference of estimated mean survival time of disease-free survival among pathological node stages except pathological node 0 and pathological node 2. Log-rank test indicate it is less than 0.05. Survival function curve of DFS, that is disease-free survival of Illinois subgroups. Here we observe the post-prognosis in high-risk Illinois group. This is very important. In PM3 we observe the post-prognosis was pathological node 2 status. And we also observe similar curves of low and intermediate risk Illinois subgroups. And there is a wide gap between these two. And pairwise comparison through using log-rank test, we observe highly significant difference between low and high risk Illinois. P-value was 0.000003, and between intermediate and high risk Illinois, it was 0.000115. There is distinct difference. On the other, again, survival function curve of overall survival of pathological nodes. Here also, same as that of the DFS of pathological nodes. And we observe, pairwise comparison observe no difference of estimated mean survival time among curves of pathological nodes. This is very important. And on the other hand, survival curves of ways of Illinois subgroup. Here again, we observe almost same as that of the DFS survival curves of Illinois. And here still the high risk Illinois curve is indicated the vertical orientation, that is post prognosis. And on the other hand, intermediate and low risk Illinois almost similar curve. And there is a wide gap between these two and the high risk Illinois subgroup. What we observe in pairwise comparison of log-rank test indicate highly significant difference of estimated mean survival time or overall survival between low and high risk Illinois. Same. P-value was 0.000449. On the other hand, intermediate and high-risk element subgroup indicate point T value was 0.000014. Distinct difference. So I don't want to show this picture. Actually, this is skin is sparing keyhole mastectomy of a premenopausal patient with a tumor size about greater than 3 centimeters. And we performed this operation at Gonoshayastha, Somaj Vittik Medical College Hospital at Savar. It's a very poor patient. So I don't want to see. Now our conclusion. Counting positive lymph node only through sentinel lymph node biopsy for pathological node staging is a powerless predictor of events and is unable to clarify prognosis. And total lymph node counts through axillary lymph node dissection. Yes, I am highlighting axillary lymph node dissection in this era of SLNB. And the sub can powerfully clarify the best and worst prognosis of breast cancer patients. Now we have I don't want to mention about this clinical study, just and we have a proposal. ELENA should replace pathological node stage of TNM classification of breast cancer. Just we should mention through superscript of number of positive lymph nodes of the total number of lymph node dissected, like pathological node 1726. This was one of my patients. Here, 17, this patient has removed 26 lymph nodes, and out of these, 17 was positive. So, clearly, it is a pathological indication, and if we can find out, we calculate out the stage of ELENA subgroup, and 17 by 1/6 will be included in intermediate risk ELENA subgroup. That's all for today. Thank you very much.
Thank you, sir, for your valuable insight.